Let me just do a few things and acknowledge a few people. First, Heather Edwards, who's over there on the side, who did a lot to work with the authors, to work with us and keeping the details going, so I want to thank her very much. Veronica Chalet, who is already left, who left last night, did a lot of worked throughout the time with Westat. Westat are the people behind us, contractors, Liz Zimmerman, led by Liz Zimmerman, who did a huge amount of work to make all the details possible. So these things don't happen without people paying a lot of attention to detail. Irene Prabhudas, who did a lot of work with the authors to make sure that we were on track. My colleague Steve Klauser, Mary Fennell, who helped incredibly intellectually, and Jane Zapka, who also helped with us putting together the thoughts and organizing this. So my thanks to all of them for their work to make this possible. Also want to thank the consulting group. There was a group of people, Tom Vogt, Ernie Hawk, led by Arnie Kaluzny, also Maria Fernandez, and I'm missing somebody. Mary Fennell was on that group. Marty Charnes, who we worked on twice and who was noticing that we worked on him twice during this conference to talk. So we appreciate their participation as well. They also contributed tremendously to our thinking and will contribute to the supplement, and I appreciate their participation in this work and the contributions that they made. I also wanted to clarify a couple of things. The questions came up about why we chose what we did and what the levels were. We set out a paper tiger. We wanted 3 levels because we wanted to push things, because we knew that there were people working at docs and working at patients. So we set a higher bar. We set 3 levels, and we actually did consciously choose to have one of those levels be patients because most of the work was in the community, and because we thought that and it was clearly a conceptual commitment, that we thought that it was important to be thinking about multi-level because of the cost, because of all the things that Otis said today, and Otis really brought us back to the beginning and the motivation for this meeting. We set out to look at 3 levels because we think that we don't do well in healthcare, and we are focused on healthcare. And yes, community has a lot of work to do and a lot to contribute, but we wanted to focus this thing on healthcare, and that means we need to make a difference in people's lives and individuals' lives, so we wanted individual level outcomes. So that's the perspective we took on setting this up. We also wanted to be clear that in the opening comments I said explicitly expand the foundation, because I grew up as a researcher at the Fred Hutch and at the University of Washington, and knew well the commit and the people that did there set the foundation in place for a lot of this kind of work, and what we want to simply do is build on the work that they've done. One of the key issues in doing that expansion is to begin not only to intervene at 3 levels, and we set that up as the paper tiger, but also to measure. And as I said in the beginning, one of the limitations and why some of these abstracts are not multi-level interventions by our original definition was that either they did not have an intervention at each of 3 levels, or they did not measure an impact at each of those 3 levels. And it's a really pretty simple thing, but it's actually not very commonly reported in the paper that you have both of those components, and that's what we wanted to see in multi-level interventions. That's why some of the abstracts did not meet the hard definition we set out. And so I wanted to just point out that we did talk a lot, and we had an active discussion, and I think the active discussion did exactly what we wanted to do. It brought up some things like the absence of the discussion, the disparities, though all of us thought about it, it didn't get explicit, and we need to talk about that explicitly, because some of what we're doing in terms of multi-level interventions is affected and does affect disparities, and we will try to think about how we can incorporate those issues throughout the supplement. I think we were open to discussion. I think the explicit discussion was helpful. I think it is clear that it's complex, but I also believe that there are ways of simplifying some of this work, and that the complexity is not a reason not to move forward. It's a challenge. If it was easy, other people would have done it by now, and we would be moving forward. I think it also is clear that there are some leadership issues. You've all heard that things change, and the people on top, and there are people that are skeptical about whether we should move forward. The question is, what does the science say? What does the problem say? And I think the problems are demanding that we think about multi-level interventions. I think there is no way around it. We are living in a world, in a complex world of healthcare. The individual reductionist approach gets us important information, but it is not sufficient. We also need to do, it's not one or the other. We need to be doing both. and we are the people, we're thinking about it. I hope more people will be thinking about it. That's part of what we want to do. We're not going to stop. This is not going to die away in the corner because there's not interest in funding at the top. There is a reason. Machiavelli knew it long ago. There are people out there vested in what we do now, in the way we do it now, and so there's going to be resistance. They're not going to say, of course, why didn't we think of it before? Multi-level interventions, let's fund them. It's not going to happen. So I think that we are going to keep going and keep moving. We're going to put the supplement together, and it does involve some risk. It does involve leadership, and we hope that all of you will take part in that. We are here listening, and we meaning the National Cancer Institute is here listening. There are editors of journals here in the room that are listening. We have at least 3 editors in the room that I know about who we hope will be affected by some of what they've heard. We also have people from the NCI besides the people on the committee, and so we wanted to get a couple of comments from those people in closing to let you know that there are people listening and to hear their perspective on what we did. So we wanted to have Bill Klein, who's the director of the Behavioral Research Program at the National Cancer Institute, just make a couple of comments about his perspective on what we've seen here, and then we'll hear from Rachel-Ballard-Barbash in the Applied Research Program. These are the 2 people that allowed us to move forward with this. Without their kind of leadership and their allowing us to move it and to use money, we would not be here. So I think it's important to hear from them and to let them share with you where they see and why they see this work needs to happen.
Well, thank you, Steve. I've learned a lot the past 2 days, really enjoyed sitting here and listening. Not only am I leaving here having learned a lot, but also I have a new team, which is the fabulous Table 7. We had some great discussions, and yes, we really got into it and talked a lot about health disparities and many other issues. And I think I now have new collaborators, new friendships with folks who have some common interests. I'm just going to take a Glasgow minute, that's what I'm going to call it, because Russ is very good at keeping people to 1 minute, to comment on some connections between what we've heard over the last 2 days and some of the values, principles, initiatives, areas of interest that we think about at NCI. And I think what I'm going to focus on here, because I only have that short amount of time, is the various other meetings that we have. Many of you have attended other NCI meetings like this one, and so you know that that's something we do a lot and hopefully do well, plan meetings around common issues. And I'd like to argue that this meeting in some ways is the glue that holds together many of the other meetings that we've had recently. So just to highlight a few. One was one that Russ mentioned that was held down in Atlanta a few weeks ago. This was a joint collaboration between NCI, CDC, and the American Cancer Society, and Otis was there and gave a wonderful opening talk. And that was focused on cancer communication science. And as Russ articulated, communication is going to be at every level of the multi-levels that we've talked about here. And so it's something that we need to pay attention to. And that meeting was all about developing a blueprint for cancer communication moving forward. We also had a meeting last month on discrimination in health, overseen primarily by Vicki Shavers, who was here and may still be here. She was here at some point. And that meeting was about how discrimination can enter into various different pieces of the cancer continuum and the health continuum more generally. So it looked at what happens between patients and providers, as you might expect, but also how does the perception of discrimination, the experience of discrimination, lead to downstream health consequences. And as you can imagine, that happens at multiple different levels. And so I kept thinking back to that meeting over the past 2 days about how the various concepts, various processes, various outcomes that we've talked about here can play out in a context where discrimination might be an issue. We also have hosted meetings that have less of a content orientation, the way these previous 2 have, and focus a bit more on the kinds of infrastructure questions we might think about in trying to do multi-level research. You know about the dissemination implementation science coming up, or at least I hope you do, and if you don't, ask Russ. There's a lot of great stuff happening at that meeting. And then we also have a meeting coming up in April on what we call the science of team science. This is a new field. It's a field, or at least it argues to be a new field, a field that focuses on how to understand team science. How does team science develop? How can it be nurtured? And how can you get folks to work together in a way that's productive? Well, team science is something that we need if we're going to do a good job at approaching research at multiple different levels. Finally, we do a variety of different meetings and other initiatives in other areas that haven't really been touched on or talked about in too much detail over the past 2 days, but are clearly relevant. And so I'll just mention one, and that is the focus on tobacco. We have an entire branch within our behavioral research program focused on tobacco, and they don't just focus on cessation or addiction, which is often the way people think about tobacco, but they focus on the entire continuum. They talk about policy, everything in between the individual decision to smoke and decisions at a policy level to tax cigarettes, for example. And so trying to think about tobacco at multiple different levels, that's something that people have been doing in the tobacco field for years, decades, in fact. And so we can learn a great deal from them in trying to move forward in the kinds of things we're talking about here. Same would be true of food and obesity, physical activity. Rachel can tell you about the work that she's doing with NCORE, the National Childhood Collaborative on Obesity Research. They take a multi-level approach as well. So essentially, I guess the bottom line here is that multi-level, in my view, is not a content area. It's not a scientific discipline. It's a value. It's a principle. It's something that is inherent in just about everything we do and everything we think about. And so it's great to have so many people at the table thinking about it in so many different ways. So thank you for being here. I thank the two Steves and their big team for putting this together, and I hope you have enjoyed it.
Well, Steve Klauser suggested I had 5 minutes. Steve Taplin said I had 1. I'm not sure if that's their perspective of what I might contribute, but I think your point about apathy, ignorance, and greed is a big problem related to our health care. I think we've actually addressed the issues of apathy and ignorance. I think we have done a very poor job of acknowledging how much greed is driving the problem in U.S. health care. And we follow the principle that free market and competition is going to get us there. We, in fact, follow that same principle in how we set up our research, right? I mean, that's what's driving how we move forward in determining how research should happen. We do a limited amount of directed research, and as our budget declines, we'll probably do even less directed research. So until we probably acknowledge that we have to consider other models in a free market economy as a way to solve this issue, I think we, in fact, might make quite limited progress. In this area, I think that we've heard a lot about the fact that we need a lot more development. We need much more understanding of measures and methods at each of these levels. Having just recently come from the review of the CA Big program where NCI leapt way far ahead of where the evidence suggested we would make gains, I think we have to be cautious about saying we're ready to institute big multi-level interventions at this point in time, but I think we can make some great gains by really improving the science about measures in these areas. This area of multi-level analysis, as Bill said, is ubiquitous in everything that's being debated at NIH right now, whether it's basic science and talking about how the cell operates in its microenvironment, or whether it's related to prevention, or whether it's related to this area. So I think the important thing is not to spend too much energy in defining what we mean by a multi-level intervention and whether or not it needs to include the patient and which other levels, but rather that we do collect information at these different levels and understand how they interact and how they're influencing each other. And I'm not convinced from what I've heard today that we necessarily always have to have the information on the patient to make progress, because we have, as was described in some other areas, made progress if we have measures across several levels without necessarily measures at the individual level. There is, as Steve Klauser noted, there have been a number of existing infrastructures that can help us make more rapid progress in this area. The Cancer Research Network is one. Dr. Collins is moving forward with an HMO-RN collaboratory to make this open to a broader array of institutes to look at issues for non-major diseases or diseases like obesity or tobacco that affect health issues for many disease endpoints. So I think an important thing as we move forward in this area is to understand that we're not going to be able to move it out of just of NCI. It's going to have to be across not just NCI or NIH, but other groups like AHRQ. That was one of the things that drove the NCORE initiative, so I'll comment on it briefly because I think there are a couple of decisions we made about priorities for that initiative that might be relevant here. For people who don't know about it, the NCORE initiative stands for the National Collaboration on Childhood Obesity Research, and the focus of that effort as a way to bring together a lot of activities related to childhood obesity by Robert Wood Johnson, CDC, and NIH was to say, what might we have in common across these groups that we could help move forward more rapidly? And it also came as the research community recognized that we needed to move beyond individual work to understanding how environment and policy was influencing what we were seeing in this country. So the focus of that effort is really on environment and policy. We felt the first need was to really enhance knowledge about measures and knowledge about data available on those measures at the state, local, and national level. And so this February, in early February, we released the catalog of surveillance systems, which has 75 surveillance systems around the U.S. that provide information related to how we're doing health monitoring in the area of diet, weight, physical activity. That is a searchable data system. And for example, when one of our fellows wanted to understand what information we had related to a parameter, I think they were looking at some measure of physical activity, in an effort that would have taken that person probably a week to several weeks to do, she did it in 10 minutes using this system. So I think we do need to use the power of things like the web to bring things forward more rapidly to the research community. We're releasing in early April effort to summarize and synopsize all of the data that's been published on measures at the environmental and individual level related to diet and physical activity. Again, it will be searchable. We will be continually adding on to those kinds of information systems. And I certainly heard from many investigators that it would be useful to have some sort of web resource that could provide some sort of similar information about what kinds of measures and metrics were available. I think Dick Scott's point about the need to really understand the social environment and how it was changing over time is very important. Ernie Hawk said today that irrespective of whether there's a research initiative in this area, cancer centers around the country are now trying to figure out how to measure quality, how to look across levels. This is happening, and we need to figure out and provide, I think, the effort to understand what are the rigorous ways to really study this area and move it forward. One of the things that I have been struck in our recent discussions about how to engage the more basic and clinical community in getting interested in this issue of multi-level analysis, comparative effectiveness research, quality improvement, is to make it relevant to the issues that they think are going to drive the future of progress in medicine. And it's at NIH and at NCI where we hear excitement in that area is in the area of genetic characterization that may help better identify those treatments that will improve outcomes and reduce side effects, and the area of prevention, because we don't have those kinds of biomarkers at this point in time. There's much more conversation about how we might build risk models that are better at predicting differential risk across subgroups of the population, and so that we're moving our interventions forward in that way. And that's partly predicated, I think, by maybe less so from some of our screening efforts, which I think we've gotten some good results out of, but certainly many of our prevention efforts, which have been quite globally focused, have not led to the promise that they were initially thought to hold. And I think that's been not true in diabetes and heart disease, but it has been very true for some of our prevention efforts, I think outside of tobacco perhaps, in cancer. And it's in part because we launched those efforts before we probably had a sufficient assessment of how to characterize and select people based on their risk. So I know this is the end of a long day, and I also wanted to comment that there are a number of other meetings that are relevant to this, and in fact are relevant to this area of work. So about a month ago, there was a meeting on CER and methodologic research. There's a huge overlap between CER and this area of research. And the issue of how to really develop standards and enhance our criteria related to external validity was a big comment that came up in that meeting. And the issue of how to come up with the right research design for the question that you're asking came up at that meeting as it did in this meeting. Other meetings that are moving forward, the HMORN is having a large meeting, as they do every year, up in Boston. And one of the sessions for that, people were asking, is there much effort to link healthcare delivery systems to their communities? So one of the efforts in that meeting is a workshop on using GIS methodology to characterize food and physical activity environments for individual and actually link that to the data on their BMIs. We don't have data in most systems on any other parameters that influence weight in these systems for kids, and as well as looking at it related to diabetes management. So I think there are nascent efforts to try to link healthcare into the community, and I think looking across a number of these levels without applying to limiting a definition of what we mean by multi-level analysis will be important as we move forward. It's been a great meeting, not in a great venue, and I hope that we will take lessons from that.
All right. Thank you all. It's been great having you here. We appreciate your activity. Enjoy the day. Thank you.